Conference will now be recorded.
No, but once you get your provisional, that's gonna go under your EMS.
This conference will now be recorded.
Yeah.
I just choked. I'm okay.
You okay?
My airway's
Upper
compromised.
airway.
Yeah. We did some arts and crafts for y'all today. Chad did some arts and crafts. I was trying to figure out.
So, how y'all feel?
Done.
You stressed out? This is bull crap. Yeah. So, like I said, the anatomy and physiology part of this class is what gets 90% of people. If you've never seen like A&P on the level that we're learning A&P, it makes you want to bang your head into a wall, which is cool. Right? I went through the same thing. I've been to EMT school, I went to advanced EMT school, I went to paramedic school, and I had to do A&P in every one of them. So I get it. Stressed me out. The thing to understand going forward is like today, you're going to see a lot of the same stuff again. You're going to see the raviolis again. We're going to be talking about this negative pressure and positive pressure systems. You're going to see all of this same stuff that you've tested over for the last 2 weeks again. And you're going to continue to see it for the next couple of months. So everything that you feel like didn't stick in your brain, you're going to see again. Right? So I get the last 2 tests are stressful. If it makes y'all feel any better, I looked at the last class. The last 2 tests were their lowest test too. So it's fine. The anatomy and physiology is it just sucks. Like there's no easy way around it. So the airway management stuff we're going to go over tonight. We have a couple of things that we're going to look at. We have our arts and crafts. We have the airway heads and stuff. We're going to talk about all that stuff. So I like airway stuff. It makes me happy. So it's going to be fun, but don't stress about it.
Yes. Does anybody have questions about that test?
Well, this is not part of it. Right.
Over there.
But it's not.
The one about the electrolytes causing cardiac dysfunction, pretty much, that was wrong across the board. I don't know what 1 or 2 people did get it right, but electrolyte imbalances will affect your cardiac activity. That's actually one of the biggest causes for cardiac arrhythmias is electrolyte imbalances. As far as the stroke volume, when it talks about the fast heart rate, that was another one that pretty much everybody got wrong. So the easiest way I know how to explain this and make it make sense is if I take a water hose and I'm trying to fill up this, water bottle or fill up a balloon or whatever, right? If it's flowing at a steady rate, it's going to be easier to fill up this balloon. Versus if I turn it on to like a high pressure system, that balloon's not going to get adequate fill. It's just going to shoot straight through it, right? So that stroke volume works the same way. It's going to decrease your stroke volume because whenever you go into some sort of tachyarrhythmia, it's just shooting the blood all the way around, but you're not getting the feeling of your heart like it's supposed to. I know.
Like that, where we're talking about if you have like a bucket and you're trying to fill a pool and you go at a slower rate, you get more fluid in that bucket, right?
Has anybody ever seen the firefighters do that? Where they like take the bucket from the bottom of the ladder. I got the big pool up there, and then I got a freaking bucket on top, like a 50-gallon drum on top. Yeah, and they freaking fill up the bucket, and they try to throw the bucket up to the top, and they go up the ladder and they dump it in the thing. Well, if you think about that, right? If you do it at a slower, steady pace, you're going to have more water in that bucket by the time you get up to the top. Versus if I just take this bucket and fill it up, chunk it up, half of that water is going to be gone by the time it gets up to the top, right? So
That makes sense.
clear as mud.
So, I wanted to show you guys a couple things. So whenever we start talking about like our breathing is a negative pressure system, we made lungs. So the balloons are lungs. This is your trachea. This is one trachea. It's two here, but ignore that. So lungs are balloons. So as your diaphragm comes down, see how the lungs fill? And they get smaller and then fill. That's how our lungs work. Our diaphragm pulls down and that's it contracting. And then as we breathe out, our diaphragm relaxes. Does that make sense? Okay. Just pass this around. Y'all want to look at it? Chaz put a lot of work into this, so don't mess it up.
It took me freaking 45 minutes to find the tools to use to put that bastard together.
They're $60 on Amazon, or they're like
How many of that cheese balls did you eat?
I didn't need any. We stole that from the hospital.
Oh.
Allegedly.
So whenever we talk about that, so if there's a hole in your lungs, we're talking about the pneumothorax, right? Pneumothoraces. Oh, I did not.
Now you did it.
Hold on.
We're never going to get it to work again.
I just click on that square. And then, thanks. Oh, thanks. See, he's still alive.
Burrow was never gonna not be alive.
I don't know. See them freaking chunky looks.
So they took a deer lung and they poked a hole in it. So they put it inside this bag. This bag is supposed to represent like our thorax, right? The inside of our chest. So there's a hole in this lung. And so whenever they start ventilating, you can see, you can, that's, you can see how this lung starts to shrink down. Because the air on the outside of the lung is more than the lung is able to expand. There's just more and more pressure building up outside of the lung because of the hole in the lung.
Just a little weak.
You don't have to talk.
He really doesn't even need the voice, you can just watch it. So, he's bagging, right? So he's ventilating. More and more breaths happen. You see this lung isn't getting as big as it initially was. I think these are a bunch of surgeons that went hunting and are like, let's do this experiment.
They're definitely in Alaska paying too much money to hunt for deer right now.
Yeah. So that lung is smaller and smaller, so it's squishing on that heart that's in there, right? So whenever we start talking about needle decompressing or finger thoracotomy, they do that here. Very short. So those lungs are to the point where they're not even expanding at all. They're gonna cut a hole in the bag, and that's what we do whenever we needle decompress. When we create a hole, or we can do finger thoracotomy. Not you guys, but this is what they need. So even this guy, when he does talk, and he's the guy that's sitting there bagging, he says like, it's getting hard to bag, like it's hard to squeeze this back. And the same thing's gonna happen in a real life patient.
You see the difference in how the lung expands now. That's
Once
just
he finds the hole. Once he finds the hole, it really. Yeah. So that's what we do to chest. And now it's like, oh, okay. I can expand again. And you notice how it doesn't fix it right away, it takes a little bit.
That's when you get air around the lung, or the
Mhm. Yeah, so whenever you get air around the lung, whether it's some sort of like blunt force trauma, or like penetrating trauma, or like spontaneous, she was talking about the spontaneous pneumos for people like Marcus. It's like tall, skinny male. Um, then that's what happens. And we have a needle that's about yay long and about yay big around that we shove in your chest to release that air. And actually, we're working on a process now to get approval through the state to where I take a scalpel and I cut a big hole inside of your chest and I shove my finger through it instead. So it's safer and more effective because this is a blunt. So I don't have to worry about that giant freaking 6-inch long needle stabbing you in a place that it don't have no business being. I can use my finger and just shove it in there and do the same thing. Safer, more effective, bigger hole. And then if it clogs up or anything happens, I can just stick my finger back in it, open it back up.
Those needles, they're long, they're like this long. So you take a needle, like I'm just this big, but you can see how far that needle can go in my chest. One likes to hang out right here. The heart, same thing with this side, right? So that's what we're avoiding whenever we stick a needle in someone's chest, we're avoiding stabbing them in the heart.
Why do they make them go so long?
Because you poke and then you feed a catheter in. You're not sticking the whole needle in, you're just sticking up into, then we have fat people, right? So you have to get poked through all of your chunky to get into the pleural lining, and then you feed a catheter in over it. So the needle itself never goes in that far, but using your finger takes all of that error, that opportunity of error away. So,
And people don't train on things and how to poke people in livers.
yeah, because you're supposed to go like here, like up high. Well, people, you go off how many ribs, you count ribs. And your first rib sits right up here in your armpit on this side. But some people start counting way down here, so they're like, oh, the 5th rib's way down here. And so they'll biopsy the liver.
Theoretically, your lung is not as big as you think it is. How low on your body do you think your lung goes? So if you take your thumb and finger right here and stick it up in your armpit, that's about as low as your lung sits.
Yeah, your hands are like, oh, it's a zip bone.
Yeah, but he's got big hands. He's a tall fella, right? So his lungs are going to sit, fairly. But that is about as big as your lungs are, right? So people think your lungs come like way down here. They're like point down here. Well, this is like diaphragm, right? Top side of your stomach where your intestines and stuff start running in. So that's about as big as your lung. And when it comes to like doing these needle decompressions and stuff, I have once heard from somebody that somebody who has air built up around their lung like that, that's the most painful thing that they've been through. So it's not fun.
Yeah. All right, so airway management. This is where things start coming together. So we're going to identify differences between pediatric and adult airway. That should be review, right? What are the differences?
Airways more fragile on adult.
Good. Yeah, the airway is real bendy in a kid, right? They don't have that cricoid cartilage built up yet. So demonstrate different techniques in manual airway opening. I have a mannequin here today, so I'll show you the different techniques. What is preferred? You're going to learn 2 different ways. One is superior, and we'll talk about that. Identify adventitious lung sounds and the pathophysiology behind them. Big words. Adventitious lung sounds, that just means a lung sound that is not normal. So normal is going to be like you can hear the air move in and out. I recommend once we get the stethoscopes out, whenever we start doing vitals and stuff, to actually just take a listen to normal lung sounds. Because once you hear 100 normal lung sounds, the first abnormal lung sound or adventitious lung sound that you hear, you're going to be like, oh, that's abnormal. So, and then the pathophysiology, why the lung sounds like they do. All right, this is in your book, but let's just chat about some important things, especially whenever you start talking about airways, right? So we have our nose, obviously, is around here. We have our mouth. This back here is our pharynx. And then, so our pharynx lies posterior and inferior. So posterior meaning what? Behind, right? And inferior meaning what? Below. Good. So behind and below the mouth and nose. So that all sits back here. And then our voice box, that's our larynx. So that's where that boundary is between our upper and lower airways. So if you ever get a test question that asks if so-and-so is below the lower airway, it's always the larynx is that point where it's the lower airway. And that's where our vocal cords sit. So you can see there's a way to do this. Let me see if I can do it. I'm gonna have to do it off the computer. We were figuring this out. I spent an hour figuring this out today, so. Nope. You guys are fighting against each other. It doesn't work that way.
No, that's the laser pointer. Go up on, yeah.
Okay,
Trash.
so right here is where our vocal cords sit. What's the little flap that sits up here?
Epiglottis.
Good. And then our voice box is this right here, right? So that's what allows us to talk, is that little vocal cords in there. So whenever we see that, and whenever I pull out the mannequin, we have our video laryngoscope, so you can see like what we're actually looking at whenever it comes to the airway, because we're looking right at those vocal cords, and that's what we're aiming for whenever we're trying to do airway stuff. This is fun. Nice. Okay, so lower airway, the larynx is the beginning of that lower airway, right? Goes into our trachea. Oh, it's already on there. I was going to say, what was this called again? But it's already labeled. So the carina is right where it splits, right? And then we go to bronchi, bronchus, bronchioles, and then what sits at the end? The ravioles. I like it. Very good. So our bronchiole leads into our little alveoli. Those are the air sacs. What happens in the air sacs? Gas exchange. Good. And what lines the alveoli? Capillaries. Good, good. Look at y'all. You're so smart.
Have y'all seen this picture before? So remember when I was saying y'all were gonna see all this stuff again?
Yep.
Yeah.
Good, good. All right, so pediatric, like we were saying, it's less rigid, right? It's bendy. It's narrow. It's teeny tiny. It's about the size of the straw right here.
I mean, that's my straws.
It's straw. It's about that size, so it's very little, very easy to kink off, right? What's special about kids' heads?
Huge.
They're ginormous. Yes, in comparison. So mouth and nose are smaller and easily obstructed. Another really important thing on this slide is the newborns and infants are obligate nose breathers. What does that mean? Yeah, that's their first choice. Their tongues are huge. Yes. Yes. So whenever you have a kiddo and their nose is plugged, that's going to affect a kid way more than it's ever going to affect an adult. I spent last week with a plugged nose. I was pissed, but I could still breathe fine. But you take little tiny kids and you plug their noses, and it's rough. It can cause a lot of problems. I'm sure anybody in here that has kids has dealt with this. Right? The chest wall is also softer, and then kids also depend more on their diaphragm because their intercostal muscles just aren't that developed yet. They still use them slightly, but their diaphragm is like the main thing. You'll hear kids are obligate nose breathers a lot. That's a lot of like test question stuff. So that's important to know. Especially like whenever we start talking about delivering babies and we're suctioning the babies, we always want to suction
the mouth and then the nose. Because their initial first breath is like, and then they'll start breathing in through their nose. But that first breath, they go mouth first, and you don't want them to suck in their crap.
So visual representation. So this is about a half a size bigger than what we use, but this is about the average.
There's a 7.5.
Oh, it's about average for like your average male. This is the size tube that we would use.
I think that's it's a 7.5.
So this is the most common tube that we use whenever we take somebody's airway. This is a kid's. So just to understand the size difference and how easy this thing is versus this, like this has like some rigidness to it, right? Versus this little thing, like there's nothing to this little thing. So just keep that in mind when she's talking about the size difference. Like that is an actual representation of the size difference between kids and adults.
So like what age do you typically start using rifle on a kid?
These,
It just depends.
generally depends on like their size. So like, now, I don't know what the freak kind of chicken they're feeding these 15-year-olds in high school, but like a lot of 15-year-olds, I can use something like this on just because of how big they are, especially like kids that just won freaking state over here. That freaking senior that went over here.
Yeah, so the general rule is for
Yeah,
like
you get one of these.
pediatrics is you kind of go off the size of their pinky. Generally, it's like right around there. So like little tiny kids got little tiny pinkies. That's kind of, if you're in a pinch, you can measure it out with their own pinky.
Yep. So. This one only looks yucky. It's just
It's
the
a little-
lubricant that we use for training. It's fine.
Just don't lick it. Just
Yeah,
don't lick
I mean,
it.
you can. A little weird, but yeah.
Yeah, sure.
Yeah, there's
So
a lot of stuff.
here's just a picture. This same picture's in your book, but this is just a visual representation of what the last slide was saying.
I can make you unresponsive in your
So we'll give them meds to keep them asleep. If we decide to take their airway and they're
Yeah.
like chatting, usually they're
Just
not
like put your
chatting.
finger on their lip.
Yeah. Jazz whips out a didgeridoo and starts like serenading the patient. But there are certain ways you can use this that the patient's like spontaneously breathing, talking to you. We go through their nose. You can nasally intubate somebody. So. It's kind of, we don't really do that anymore, but we still learned it. So. All right, so airway pathophysiology. What's going on in here, right? So obstructions interfere with airflow. What is the number one obstruction? It's going to seem so simple once I tell you. It's the tongue. Yeah, it's the tongue.
I'm like, I read that.
Yeah, yeah, it's the tongue. So what's that? That's what they're talking about, that loss of muscle tone. So the general rule is if you walk in and the patient is unresponsive and you hear snoring respirations, that's their tongue, right? It's flopped. The whole saying that somebody can't, like they swallow their tongue, that's not a thing. You'd have to like, and then swallow the tongue. That's not a thing. It just relaxes and it covers that airway. And so we're going to teach you a couple different ways to get that tongue out of the airway without like cutting their tongue. So obstructions can be acute or chronic. I recently had a patient that had a tumor in his airway. And so when I walked in, like he clearly was in respiratory distress because of a tumor. That's a chronic problem, right? Another obstruction that can be chronic is asthma. Even though that's not up high, it's down low, that's still an airway obstruction. So asthma, COPD, any kind of like obstructive thing in the lungs, that can be a chronic problem. Whereas acute, we're talking more of like the kid choked on a hot dog, like anaphylaxis can make your airway swell. like caustic inhalations. If somebody breathes in some kind of gas or something that they shouldn't be inhaling and it burns the inside of their airway, that can cause an obstruction as well.
House fires.
House fires, yeah. All right, so we talked about this severe anaphylaxis. So any kind of airway involvement with an allergic reaction is anaphylaxis. So that can lead to rapid airway tissue swelling. I think I have a picture here. This is what I've learned. You won't find this in a textbook, but this is just me doing it. If I have somebody that has an allergic reaction, even if they're not like physically wheezing, or if they're like, yeah, you know, I'm still okay. If their voice sounds like they're talking through marbles, or even if it doesn't, if you have them open their airway and you take a look and that little dangly thing in the back of their throat, their uvula, looks like a grape, that is impending airway failure. They need epi now. Never be hesitant on giving epi. I've had patients that are talking to me like I'm talking to you now. They're like, yeah, I got some hives, called for an allergic reaction. I'm like, okay, let me see your throat. And I looked right at this and I was like, you earned this medication. So just be mindful that it's not always going to present like they're half dead. Sometimes like things develop quickly. So be mindful of that. Burns, blunt force trauma, and then smooth muscle constriction of the lower airway. So that's our asthma. Any kind of bronchoconstriction. That's the name, that's the word you're looking for there. So broncho being the bronchioles, and then constriction is they close. So this picture right here with the guy with his red on his neck, this is caused from like a mouth infection. So you can have where your tooth's infected and it can get down into like your manubrial like space here. And it can lead down, there's a fancy word for it, it's called Ludwig's angina. So I've also had a patient that they called 911 earlier in the day for a toothache. A crew went out there, was like, you don't need a doctor, go to a dentist. And then I got called back out there 2 hours later and he looked like this. And so that can cause, even though it's coming from his tooth, that infection has spread and it's going to crush his airway. So those are things that you need to be mindful of. And this is why we do really good assessments on everybody. Like you're going to get a call for tooth pain at 3 in the morning and be like, God dang it. But always make sure that you're checking for stuff. I can't say because I wasn't there.
We do not Monday morning quarterback.
Yeah.
We just deal with it as it comes.
Mm-hmm. But just know that it's something that can be missed.
And you should check.
You should check. So here's that bronchoconstriction. So bronchioles, and then constriction, it's getting smaller. And not only is it like swelling and getting smaller, is
No.
It's only 6:10.
that is not our test. I think I know exactly what.
Yeah. RSD 7 or clear with them.
Okay, so not only is it a squeezing problem in the bronchioles, but there's also a buildup of mucus when it comes to like asthma or this like COPD. There's a buildup of mucus as well. So there's multiple things like working against your patient for them to be able to breathe. They label it here, but you can't really see it. That's what I thought. So what kind of sounds, what kind of adventitious sounds are you going to hear if somebody has bronchoconstriction? Wheezing. Stridor is an upper airway problem. Wheezing is a lower airway problem. So this is all in the lower airway. So this is going to be wheezing. And do know that whenever you do listen to lung sounds, you can have inspiratory and expiratory. So as they breathe in, you'll hear a wheeze, and as they breathe out, you'll hear a wheeze. That's what we're talking about. So inspiration, they breathe in, and you'll hear and then as they breathe out. But you could have one or the other. So it's not always like super obvious. Some patients, it's kind of interesting, like they play mind tricks on you because you'll hear like a slight wheeze and then they'll cough and then their wheeze will go away. So just make sure you're listening to lung sounds. I got some videos here. So stridor, like we were saying, that's indicative of your upper airway obstruction. So that's the noise that I made for y'all the other night, but I found a video of it. See if I can get it. No. Why did it do it? All right. After we watch this end. And I apologize for the sound. Stridor, and if you ever walk into the house and hear that from the door, your butthole should go twink, because that is not a good sound. Stridor is bad. Those are the notes, right? So this is snoring. You guys all heard snoring, but I can't do it.
Oh, that's our chihuahua.
So snoring, so remember snoring, that's also an upper airway problem. What's snoring usually caused by? All right, some other sounds. So these are sounds of a partially obstructed airway. Do know that if their airway is partially obstructed, 9 times out of 10, that is impending that their airway is going to be fully obstructed. So always anticipate this. Don't be like, oh, it's stridor, it's only partially obstructed, they're fine. Just know that this patient can progress and it can get way worse, right? A hoarseness, that's kind of what I was talking about, like, especially, you see it in anaphylaxis, like somebody there, they don't sound like a horse, like, hey, but they'll, like, it'll be hard for them to talk. It sounds a little muffled. A big thing too is like any kind of burns or suspected burns, house fires, smoke inhalation. That's also what you're looking for. You're listening for that. And it's okay if family's around or whatever to ask, like, does this person normally sound like this? Because some people just have that voice where it's like sounds hoarse all the time, and that could be normal for them. And then gurgling, of course, that's a horrible sound. That means that there's some kind of fluid in there that shouldn't be. So what do we use to get rid of that?
Suction.
Suction. Good. What if you don't have suction readily available?
Clean them wonders.
Good. Yes. Put them into a lateral recumbent position.
A roll.
Yeah. Roll them. She's puking. She's puking. Yeah. So Chaz and I, we ran a call one night. We had a student with us. Her name was Mo. She's pretty cool. She needed one more trauma call for her little checkoff. In Atlanta, you had to have like an X amount of trauma calls, X amount of medical calls, X amount of peds, whatever. It wasn't just like a 24-hour shift. So she needed one more trauma call. And we're like, okay, we're going to get it for you. We had like 2 hours left till our shift changed, or yeah, our shift ended. So as we're leaving the hospital or dropping off another patient, we see like this car flipped on the freeway. We're like, that's ours. Like, this is her call. So we pull up and this lady's like unresponsive, laying in the middle of the street. And she's laying on her back. And I see like something kind of come out of her mouth and it looks like a little tiny piece of crab. And my student's like, she's puking, she's puking. And so I'm like, roller. And Chad's like, I'll go get the suction. So he runs over and grabs the suction. Listen, these suction machines, you can check them 10 times the morning of your shift, but when you actually need them, they're not going to work. That's just how they work. So he runs up and he's like, it doesn't even work. I was like, great. This is awesome. So,
Yeah, and then we dropped her off and our supervisor was there. He was like, oh, y'all didn't check your truck this morning? I was like, I checked this freaking truck. And I walked over there and clicked it. It was like, burn. I was like, mom, piece of junk.
yeah, it was great. All right, so our airway assessment. So you can start assessing the airway as soon as you walk in the door of a patient's house, right? So if they're talking to you, usually that's indicative that it's patent, right? You can also watch your patient. I don't have to be like touching my patient to figure out if they're standing like this or if they're sitting like this. What is this position called? Tripod. So they call it tripoding. So if you walk in and your patient's doing this number, that's usually indicative that they are having a hard time breathing, right?
A lot of times they will have their head inside of a freezer.
I don't know what it is that like people that are really struggling, I think they think the cold air is going to help them, and so their head will be like.
I don't think so.
For like croup, for croup, it's a great thing, but
Yeah.
for someone that has like asthma stuff going on or like a buildup of fluid in their lungs, that's not going to help them at
No,
all.
but you would walk in there and they would be face deep in a freezer. You're like, all right, come on.
Come on, let's go. So the questions that you need to ask yourself mentally or out loud, is the airway open? So if they're talking to you, their airway's going to be open. And will their airway stay open? So that's what we're talking about, that impending like airway compromise kind of thing. Airway should be on the number one thing you're checking off, right? Unless they're completely unresponsive, then you need to be checking one. So if it's partially obstructed, know that it's only a matter of time until it's fully obstructed. A lot of times, if you're not able, like say it's a choking, right, and you're not able to clear that airway, you need to get ready to do CPR, right? So we learn once they go unresponsive. But if they're able to like talk to you, say, I'm choking on a cracker, what do you do? Tell them to cough. Good. So any airway problems need to be fixed immediately. Unless they're actively bleeding out, then they almost immediately. So airway problems, if you don't have an airway, you do not have a patient. So as soon as you walk in, you say, you do your initial assessment, you hear a snoring, gurgling, nothing, that needs to be fixed right away. And then make sure you're reassessing your patient. So this is a big thing. You should be continuously assessing your patient. The textbook is like, if they're unstable, assess them every 5 minutes. If they're unstable, or if they are stable. If they're unstable, it's 5 minutes. If they're stable, it's every 15 minutes. This is one of those things that if you're worried about airway stuff, you need to be continuously assessing them. I sit next to the patient, I watch them, I talk to them if they're able to talk. We do like, give me a thumbs up, they'll give me a thumbs up depending on if they can't talk. So that's something you always need to be assessing. So signs of an inadequate airway. Again, no signs of breathing or air movement. If they're not breathing at all, you need to fix that. If there's evidence of foreign bodies in the airway, that also needs to be fixed. If there is no air felt or heard around the nose or mouth, that's why we get so close to their head whenever we're checking for a pulse. If they cannot speak or they're having difficulty speaking, and that's not only because of like a Schreider thing or like an obstruction. If somebody's really struggling for air and they have asthma, a lot of times they'll be able to talk in like 2-word sentences. If anybody's ever watched somebody else have an asthma attack. So we call it 2 to 3 word dyspnea. Dyspnea. So what does dyspnea mean? Difficulty breathing, right? What part of that word means breathing? Pnea. Good job. All right, so absent, minimal, or uneven chest movement. So it's important, especially with kids. This is gonna sound horrible, but you need to get them like naked, right? So little tiny kids, when they're having trouble breathing, we'll see some videos here. They're still standing by.
Response to 716 Girls Are So Happy for
Of course she is. I'm sorry. I wasn't-
Is this a repeat offender?
Yeah, each little lower. They're like every freaking week, literally every week.
All right, so whenever you're assessing a kid's breathing, you need to take their little onesies off, take their shirts off. That's the best way to assess a child. Yeah, and most of the time we have them because they have some kind of fever anyway, so it kind of helps out. It's like a twofer, but you do need to expose their chest. Adults, it's a lot easier because we are bigger, so it's easier to see. So uneven chest movement, that's where like our pneumos come in, our hemos, that kind of stuff. The best way to assess for chest movement, I like to grab their chest and put my thumbs together like right at their sternum. And so whenever they take a breath in, if one of my thumbs moves more than the other one, you can like clearly see that their chest is unequal. Because even if they are hurt and they're trying to take shallow breaths because their ribs are hurt, they're still not going to just be able to move one side of their chest, right? So that's a good way to assess. What is cyanosis? It is low oxygen, but it's a sign of low oxygen. Yeah, they turn discolor. So you can see it around their mouths. You can see it around their like the beds of their little fingernails. Here's another example. So this person is clearly very sick. They also have clubbing of their fingers. We'll talk about that later too. But if your patient is this color, they need oxygen. There are very few pathophysiologies that I can think of that like the person is just naturally like they're blue and they're not hypoxic. One of them's like the silver poisoning or whatever. Another one is like some kids are born with, they call it tetralogy of Fallot. And those kids always have low oxygen saturations. But you're going to know that if you get called out to a tetralogy of Fallots. The moms are going to know, or the dad, whoever's taking care of them. But blue, bad. Cyanosis means blue. All right, kiddos. So you can kind of see the blue toes here. And then around his mouth also looks a little bit blue. Sometimes this is subtle, but it's important to be able to assess this.
That baby's not getting there.
Correct. Not getting.
Is it? What, yeah.
This season, you've got places to go, people to see,
They're hypoxic for some.
and things to do. You have a flu and
You'll see it. So kids, whenever they're trying to like compensate for having trouble breathing, if you watch their nose, their nasals, nostrils, their nostrils will flare. I knew that wasn't my word. He's like, Mom, Ella's gonna came running. So very subtle. Unless you're looking for it, you're probably not going to notice it. And then here's the other one. So this is why it's important to take your kids' shirts off and put them. You see his little intercostal retractions? So he's struggling. And I think in this video you can hear it too. He's got like some gurgling going on. Just like me. So, expose your child's chest. Sometimes they just don't like it, but
So if it's one of those ones that like buttons at the bottom, do you take the time to like take it off? I would, I'd probably take the time, those things are expensive, depending on how much I got, right? So like if the kid's like, Jesus, I'm gonna cut it, but, I'll probably take the time. A lot of times with like kid respiratory stuff, they look a lot more scary than they really are. And then you go to like treat them and they turn around so fast. Like adults, you treat them, it takes them a second and then they'll turn around. Kids, they look like they're about to die and then you give them like a breathing treatment or something and they're like, ah, they like chill out immediately. It's ridiculous. Bless you. This is another video.
So you're getting about 90 undress, and so that he has a VSD and ASD, a little pulmonary stenosis in this.
Alright, what's tachypnea? So they counted it, this kid's breathing 92 times a minute, which is wild. Like for an adult, 30 is like, but for a kid, like, whew, okay. And then you can see his little muscles retracting.
Deep and sick, coughing, no fever, you said, right, but he's been coughing and he had a period of apnea, is that right? He just stopped breathing on Monday, and someone had to blow in his face, is that right? Okay, but he's only had like, what, 2 ounces today, so, yeah.
So again, they only need a liter of oxygen and he already, like kids turn around so fast. No, I don't want to. Okay, there we go. I want to listen to Pocahontas.
So kiddos, they can be scary. Keep it calm. It's okay. So if you have a patient that cannot maintain their own airway, it is up to you to maintain it. When we talk about maintain, we're talking about making sure it's clear. We suction out the airway. We insert adjuncts as needed. We breathe for them. We continuously monitor. Is a patient that has puked once before is probably going to puke again. So in suspected spinal trauma, especially if they're unconscious, you want to protect the head and neck. So we'll talk about the different ways to open the airway, whether they have head trauma or not. And then any kind of maintaining the airway is going to be easiest when the patient's laying flat on their back and you're sitting right at their head. Like we learned in that CPR class how it's easier to bag when you're right at the head. So this says easiest when patient is supine. That's straight out of your book. It is better for the patient to have them slightly elevated at the head. It is easiest when supine, but we want to do what's best for the patient. So we'll teach you that.
Is that position?
Yeah, so there's a whole slide here with a picture of like the sniffing position that will show you. It's like an ear to sternal notch, or an ear, yeah, to sternal notch or nipple. Like you'll see a good picture of it. So whenever you have spinal trauma, if it is suspected, we're considering the mechanism of injury. So what caused this patient to be hurt? So if they have a significant mechanism of injury, they were in a vehicle that rolled 6 times, or they were ejected, or they fell 3 stories onto concrete. Like those are significant mechanisms of injury. If they stubbed their toe and fell onto their knees, probably not. It's no spinal trauma, right? But do know that your airway management does have priority. So it is life over limb. You'll hear us say that a lot. And if they have no airway, they have no life. And so you protect the airway over spine. If you have to choose one or the other, it's going to be airway. And then manual stabilization. So that just means you're holding their head in an inline position. I'm not gonna, if I walk up to somebody that's been in a car accident and they're looking at me like this, and I'm not gonna run up and hold their head still. If they're moving their head and they're with it, it's fine. But just know if like someone's completely unresponsive, that's something you want to consider. So here's that sniffing position we were talking about. So in supine patients, if it's an adult, we're gonna try and put as much padding up under like the head, kind of the shoulders area. We're aiming for this here. This ear to like nipple line or ear to sternal notch. Like we want to make sure it's all in line. This can be very difficult with like bigger patients. You can use blankets, blood pressure cuffs actually work really good. You shove them up under there and air them up and it'll bring their head up a little bit. This is ideal in any, from here on out, once you start going from EMT to like AEMT to paramedic, this position right here is ideal for your patient, right? So technically it's not supine. Technically it's like a half Fowler's. But you can see like your airway anatomy is perfectly lined up. I wish they would have drawn a line right here. This is like a perfect line rather than being at an angle. It's a perfect line into their mouth. So here's just a visual example of those kids. We talked about this a lot on Saturday, so this should be reviewed. But kids' heads are huge, so we pad more behind their shoulders than we do behind the back of their head. Also know that this can be really difficult. If you have a patient, how many of you guys have seen like the older ladies, or usually it's ladies, but they have like that kyphosis where they have like that big old hump right here? That can be hard to get somebody in like a good position. Just work with what you can. Be a MacGyver about it. Kyphosis. That's kyphosis. If they have on the lower back, it's lordosis, and I remember it because they go, "Oh, go it." Yeah, up here, that's kyphosis. Yeah.
So Hunchback of Notre Dame.
Yes, he's kyphotic. So again, pediatric patients, their heads are ginormous. All right, so manual airway openings. I'm gonna bring out my little thing. But we use these on our patients without an intact airway, so we need to monitor their airway for them, right? So there's a couple ways that you can open someone's airway. If they, I'm trying to, so if you're not suspected, if they don't have suspected spinal cord trauma, you can do a head tilt chin lift. So head tilt chin lift, you just lift it up. What this does is it takes the tongue out of the back of their airway and it moves it out of the way so air can get by. So if you go in on an unresponsive patient that is snoring, this is what we were talking about, that EC technique. You're trying to bring their head up, head tilt chin lift, right? If they have suspected spinal cord trauma, or this is just ideal, this just works better. So the book's going to tell you one way or the other. If they don't have spinal cord trauma, head tilt chin lift. In real life, this is really going to work the best. So you take, it's called a jaw thrust maneuver. So you take this notch right here behind their ears, like right where their jaw comes up and connects. You're going to put your fingers there and you're going to lift their jaw up. So this guy's hard because he's a mannequin, but in a real patient, he has a whole body weighing him down. So you can just take this and open his airway. So I'm not cranking back on his head. I'm just taking his jaw and lifting it. Does that make sense? If someone is unconscious and they have a pain response, like they can still feel pain and they'll still do stuff to pain, they're going to do something because you have pressure points right here that's going to hurt. So do this number, lift up their jaw, and then you're holding the mask on their face. This is why that the two-person BVMing is going to be best. So one person can hold their jaw, hold the mask on the face, and the other person can back. Does that make sense? And this is not easy. Airway management, I feel like there's like a, what's the word I'm looking for? like it's not on the forefront of everybody's mind. Everybody's like, yeah, airway. But then we always take like the least experienced provider and was like, yeah, bag them. I got other stuff to do. But this is more important than anything, and it's one of the most difficult things that you can do for your patient. Everybody thinks that they're good at bagging a patient until they do it. It just sucks. Your hand starts cramping, keeping their airway open sucks. So it's one of those things that you need to practice a lot, because practice makes perfect. So head tilt, chin lift. Again, you just crank their head back. And then that jaw thrust, you're just taking their jaw and moving it up. We talked all about this on Saturday. So hopefully this is all reviewed for you guys. So choking patients, how do we help somebody that's choking? Abdominal thrust, not the Heimlich. Oh yeah, and the back slaps now too.
Per age, I guess.
Yeah, so pinky in the belly button, take your thumb or your fist and roll it up. It's right where you want your fist to go. What if they're too big around and I can't get my arms around them?
Elbow drop.
You can't punch them in the stomach, you do the same thing. You're gonna do it on their chest. Same thing with pregnant ladies, right? We already know this. I had to add this today. The back slaps. The HA. What happens when they become unconscious? CPR. And then whenever you bag, what are you doing? Looking for objects. Never perform a blind finger sweep. If you can see the object, get it out, but don't just go in there like, there it is. Don't do that. There you are. Easy peasy, right? How do we fix choking in infants? Good. On the front. Good job. Do not suffocate the baby. Please. And then if they become unresponsive. CPR. Good job. I learned something. Yeah, I was trying to find the video. The dog is like chewing on his stuffy, and he's like, and the little fuzzy like flies out. I couldn't find it though, so y'all have to do it this year.
Like I'll save that for later.
Yeah, he was. Yeah, he's like, look at this. This is my file. He's the Napoleon Dynamite dog. Oh, also, we got this thing out earlier. Who was in here was saying that they wanted to drink.
I want to see what it looks like, and I said I might try it.
This is what it looks like.
That's what it looks like.
That's the whole thing.
You can drink that
Yep.
whole thing without puking.
Whole
You know,
thing.
shot, that's.
That's big. I thought it was gonna be.
Right?
I guess you put in your water bottle or something?
Yeah. This is it.
You got this.
That's what they- that's what you put in the-
Yeah. That's a lot of work.
So, we open the airway using manual maneuvers, but then we use our adjuncts to kind of help keep that airway open, right? What's this called? OPA. What does OPA stand for? Almost. Oropharyngeal airway. Oropharyngeal, because it goes into the pharynx, right? So do I just pick a random size and like go with it? Measure it. Good. The corner of the mouth to the ear. So make sure you always have suction ready whenever you're going to stick this in somebody's mouth, because if they have a gag reflex, you're going to trigger it. And then some people are just really popular and they don't have one at all. So, like Chaz was saying, I can count on one hand how many times I've used one of these in my career. I don't use the OPAs very often. If I'm going to do an airway, I'm going to use like an NPA. And usually it's for those overdose patients that I'm trying to bag up before I wake them up. So yes, you measure it. Let me see if you get in front of the camera. Measure it from the corner of the mouth to the earlobe. Now, do I just shove this thing in? No. What do I do? Towards the roof of the mouth, and then I twist, right? So they are different. Why? Their tongues are huge, and then the top part of their mouth, yeah. Their palate up top too sensitive. You're gonna poke right through that thing. So another thing with adults, whenever you're putting one of these in, you can go completely upside down and turn. That's fine. I go through the side of their mouth. I kind of prop their mouth open and then I just twist it. That's just how I do it. The few times that I have done it. How's it going?
Listen, you can talk crap about your people before you get there or after you leave. You just gotta be nice while you're there.
You're not.
Huh?
You're not.
I don't want that. It's yours.
Get nothing away from
No, it's not. It is.
What is this?
the nasal
I'll take it home.
Yes. Very good. How do I put this? How do I measure this?
From the corner of the.
Corner of the nose. So it's going in the nose, so you're measuring it from the nose to the ear. So the textbooks are gonna be like beveled towards the septum. So what it's talking about is this is a beveled edge. It's angled like this for the camera. They want that facing towards the septum. I will say it does not matter. It really doesn't. So whenever you get out in the real world,
Doesn't
it
matter.
doesn't. So you move it up
Or stick it in their mouth.
or stick it in their mouth. They got goop in their mouth, that works great. That, your textbook also doesn't say that. They probably say not to do that. I'm not
It's
going
fine.
everywhere
No,
to
it says
find a
put,
lube packet.
Water-based lubricant.
Yeah.
Yeah,
Water.
saliva is water-based. So my pet peeve here, and Mike Hoover is gonna be teaching you the next Saturday, and he's really good, but this is my pet peeve. So whenever I go to put an NPA in, the bevel's towards the septum, your initial, like, your gut instinct's gonna say to shove it this way. You don't do that, okay? You want to, because the nose is faced that way, and you're like, that just follows it. Now your airway goes like this, right? So you take their nose, you give them a piggy nose, okay? And you go straight down. You don't go up, you go straight down. So straight down. Now what happens, what do I do if I meet resistance here? You can pull out, try the other nostril. You can just kind of twist it. You kind of twist it, it works around like whatever ridges or bumps or lumps it's getting caught on. And you just push it all the way. Should be flush with the nose. Now I just learned this recently in my critical airway class. If you have one NPA in, why don't we just put two in? They're getting more airflow, right? So why can't we just put two? So if you ever see somebody with two NPAs, it's not abnormal. I just learned to do that. So you can put two in, kind of get everything oxygenated. Some patients, if you go to put it in, just be mindful. If you look at nostrils, usually one's bigger than the other. Yeah, just try and aim for the bigger nostril. If you're having too much resistance, yeah, pull it out, try the other side. But that little twisting motion gets it past more times than not. Sometimes if you chose too big of an NPA, even normal NPAs actually, I say, you go to put them in and you'll hear like a pop. You'll feel a pop. And then sometimes you look at the back of their mouth and they'll have like a little bit of blood back there. If they're bleeding excessively into their mouth, suction them. But usually it's just a tiny little bit. But just know you can.
And you'll meet a lot of resistance.
A lot,
Yeah.
yeah. And that's switch the stuff.
Generally, if you hear the pop, you're just popping their sinuses.
Yeah. And apparently it's not very fun.
Yeah, it doesn't feel real good, but it's
Yeah.
fine.
Yeah, you have little turbinates that sit back there. They're like look like little pockets, kind of pop through. But
It's fine.
yeah, it's okay.
It just makes a weird noise.
Yeah. So when am I using these things?
When they have a gag reflex.
When they have a gag reflex. Good. And what if I'm putting this thing in and they're like completely unresponsive, but they're like, what am I gonna do? Okay. What if I put one of these in and I'm bagging them, I give Narcan, and then they start to take it out. Yeah.
Typically, y'all can, this will be your best friend in a BLS cardiac arrest. If you're by yourself or you're on an ambulance, like at the mine site or whatever, and y'all have these, they work really good for opening the airway so that you can bag somebody really well. Typically, if you feel like they're going to wake up, just use the NPA. It also works really well. That's what we use for our overdoses. People will tell you if somebody's overdosing to use one of these. Well, that's what you're going to run into, right? The second they start gaining their stuff back, they're going to start gagging. They're going to throw up. Avoid it. Use NPA. They're not going to like it. They're going to wake up and be like, where's your oh, shit,
Sometimes they
man."
wake up and they don't even know it's in their nose. So it's a 50-50.
Yeah. So I do know somebody that woke up and didn't really like it that much.
I had a dude that woke up once and the paramedic I was with put too big of one in his nose. And so it was like hanging out in the back of his throat and he was trying to talk and he was like, oh. So it was kind of funny. But these things get huge. So don't be like, that person's really tall. They need the biggest NPA I have. Make sure you're measuring them. Just to put it into perspective, how big these things get. Billy, did you want us to show one today?
No. I'm not going to do that.
Why not?
No.
He offered. So here's our suction tubing, right? Just to put it into perspective how these things get, how big these are. Huge. Nobody ever, unless you have freaking, what's that basketball player? Shaquille O'Neal freaking in your ambulance, should you ever use these. So, we used to carry that size and that size only at Grady.
Maybe sticking this far out, I guess.
Yeah. Yeah, so for kids, you can use like a tongue depressor. This is our tongue depressor. If you have a popsicle stick, that works too. So just move their tongue out of the way, shove the opiate in. Yeah, little wee baby one.
Little baby.
This baby actually takes it pretty big. I'll pass this around. But yeah, if you're dealing with a kiddo, move their little tongue, their big tongue out of the way and kind of just go behind it. Don't do the twisty thing. Their little palates aren't built for that. So.
Is that the biggest one?
Huh?
The biggest one back there?
Yes, you do have a biggest nerve back there. So kids especially, do you like to play with their little?
It innervates things there. It resides in a different spot.
It lives somewhere else. But if you be messing in the back of someone's throat, you'll trigger it. Yes.
But
Good.
their palates get cut up real easy, so that's what you gotta be worried about.
Yep. She's like, yeah. So you can also, for the OPA, you can do either the ear or the angle of the lower jaw bone. It all sits right here. So measure it from here to here. Here's them measuring it. Again.
Did you see the doctor?
No, we're not sticking Billy with NPA.
Oh,
No, he's already passed this class. Somebody in this class wants to get stuck with one, by all means. He's already gone through the torture of this class.
the torture. I had fun.
They look like they're having a grand time. Half of them walked out and almost cried after the test.
All right, so MPAs, they can look different too. They don't all look like this. Some of them are orange, some of them are green. Some of them have like the little circle part that sits right here actually slides down. So if you're putting it in someone's nose and it's still like partially sticking out, you can just take that and like measure it to their nostril.
But they're all Frenchies though, right?
They are measured in French, yeah. So French, it's backwards from like IV needles. So the bigger the number for French, the bigger around it is. ET tubes are measured in French. IV catheters are not measured.
And when we start talking about like nasal cannulas and stuff, you can stick those in and stick the nasal cannulas into them as well.
So I have a question. What if somebody has a lot of fishing tackle in their face? Is that getting away?
Yeah, trauma gears have like ring cutters on them.
Oh,
They're that big of a problem.
Yeah,
The Raptors do.
yeah, I can cut a lot of things.
We have ring cutters on the ambulance. So like, if it's a problem, it's gonna get removed.
And if it just pisses me off bad enough, I'll just find a big enough magnet.
Yeah. I mean, unless someone's like, no, like pierced all the way, you can't get anything in there. I've never had a problem like that.
No.
Okay, good. Very good. Where does the bevel go?
Where does it sound?
Where does it say?
Towards stuff. Just stick it in.
Okay, it says avoid causing airway trauma. It's gonna happen. So yes, avoid it. Don't go like shoving it in there, but just know you can still cause airway trauma. And then if it's improperly measured, especially the NPAs, you can actually bypass because they're so long. I don't know. Because the NPAs can be so long, they can actually bypass like the esophagus and the vocal cords and just start pushing air into the stomach. So that's why we make sure we want to measure them correctly. So what happens when somebody gets air pushed into their belly? Yes, they turn into
Yeah.
this. They turn into this right
And
here.
as the EMT, you are responsible for catching it,
Yes.
because I'm gonna get out of the truck.
Okay, so here's the advanced airways. These are in your book. I'm pretty sure there's a whole section where they like have you help assist with airway, like advanced airway. So here's our eye gel. You've seen this one. It's floppy. I don't know why y'all can't do these. They're easier than the OPAs and they're more efficient. This is the King Airway. Very similar. You literally just shove it in and blow up that balloon. These, there's been a big recall on them. So I don't know of any place, Elko County still has them.
Yeah, but they suck, so.
Yeah. So these aren't very common anymore. I used these when I first started EMS like 10 years ago, and I haven't seen them since. This is that ET tube that we were talking about. So that's paramedic skill. It goes into the vocal cords, into the trachea. These three, the iGel, the King, and the LMA, they all sit above the vocal cords, but the ET tube goes into the vocal cords. So that's the difference. And then this is the LMA. Again, it's just, they're all vaginas on sticks. I haven't seen an LMA in a really long time. I think I seen one when I was training to be an AEMT, like in class, but I've never worked for a place that had them. There's another one that you might hear. I don't know if it's in your book or not. It's called a combi tube. Those things are like freaking 80s. Like those.
They look very similar to the Kings, but they have like
They have
multiple
two
ports
balloons,
that you
yeah.
have to blow up.
Yeah, they have two balloons, two ports. It's just another form
Pain
of
in
the
the
same thing. Yeah. All right, suctioning. Here's our suction device. What do we want to make sure it's suctioning at? Millimeters. Huh? 300, yes. So you turn it on. It does this little thing. Then as it suctions, there we go. As it suctions, you'll see the little green light go up, or it should.
This is our training one, so.
No, it's not gonna work. It was literally working earlier. I told you. I told you, you check them off and they don't work and then they work. Anyway, that little green light goes up. You'll see it go to 300. That's where you want it to be. I'm not saying turn the knob to 300. I always turn it up past, and then like once I suction, you can see it. So these are the ones we carry. These guys right here. You might see other ones. These little manual ones.
There it is.
Suck
So you see the little green lights coming up?
right here. So it tells you how much is being suctioned.
Yeah.
So he's turned up all the way to 500, but it's only pulling 350-ish. So turn it on. Okay. These are little hand pumps. I've only ever seen these on like QRV units or like in little rescue packs. I've never seen one on an ambulance. I've heard that they don't suck.
Yeah, they're not very good. I think
They suck at
Jackson
sucking. Yeah.
Jackson County had some on their trucks, but nobody ever used them.
Yeah. And then these ones, every time I've seen one of these, I always have a hell of a time trying to find the little on switch. It's like hidden back on the other side, like right in here. But just like be familiar with your equipment, whatever you
Pretty
guys
much.
carry.
This is like kind of the predominant unit you'll find as far as like mobile suctions, and then we have a secondary suction that sits in the truck. That's just stationary, but this is pretty much everybody has this same style.
They're very common, these kind of. So they plug in, there's a little plug in the back, a plug into the wall. So fantastic when you need them. So if there's foreign materials in the airway, obviously we're going to try and suction them out. If, again, we talked about if you can't get, suction there right away, then turning them on their side's the best bet. Usually they say turn them on their left side. I think I haven't gotten a good explanation as to why the left side for this scenario.
That be because of the famous ones that you said, how
The right main stem, probably. That would make the most sense.
Yeah, but that's still, I mean, theoretically, it's going to travel with gravity, so it doesn't matter if they're on the left or the right, it's still going to go into whichever lung they're turned on, so.
I've always heard it being stomach, but.
The pressure,
Yeah.
that would make them.
I also heard a theory that they say left side because the cabinets are always on the right side of the stretcher, so they don't puke on the cabinets, which I would concur. That sucks to clean up. So one of the only freaking bickers that we got into was this lady puked strawberry cake all over when we were cleaning it
And
up.
tequila.
And tequila, yeah.
It's freaking disgusting. It was everywhere.
It was bad. So here's that suction device Chaz was talking about. These are mounted in the ambulance. There is a row of buttons over here, like next on the other side of the oxygen port. And one of them says either vacuum or suction, and you hit it, and that's what turns it on. Whenever you guys do your ride-alongs, just kind of look around, like you're able to look through that stuff. Find it, know where it is, because when you need it, you're going to want to know where it's at. They also recommend keeping a container of water. We carry little bottles of sterile water, so if that gets blocked for whatever reason, whatever you're sucking up might get blocked in there, you can stick the nozzle into some water and it'll clear it out. And then you can keep suctioning. We had to do that on a lady that was puking up salsa. So, works good.
And then if you ever have problems out of this thing, the first thing you want to diagnose after you make sure it's on is right here where this white little cylinder is. There's a little black knob right there. That's your adjustment for the power for the suction. So if it's just not working, the first thing you want to check is that to make sure it didn't get turned or rotated, so you're just not getting it into suction. So you can turn that off and then see if that'll help. Because you got your little gauge right here that'll tell you how much pressure it's actually pulling on suction. So
Yeah. So just like there's a lot of holes, right? So this is where the main suction part goes into. One says patient. One says patient, one says tandem, and this is just a big one. So the big one always stays shut, and then your suction tubing hooks either to this one or this one. Usually when you're troubleshooting, if you're not getting good suction, check for cracks in this. If it's cracked, you're not going to get good suction. Make sure these are secure, the two that aren't hooked up to tubes. Make sure that those are on there good. And then make sure the lids on are good. These lids are real funky, and they like to sit a little bit off like that. So just grab it, make sure it's all the way around.
even something simple like one of those little caps gets up under there and you close it down on top of it, just that little tiny connector for that cap will cause that thing not to work. It pulls a lot of pressure, so if you close that cap in there, it won't work.
And that's why we recommend checking them before you
Need them.
need them.
That is called your morning inspection.
Yeah.
Off your truck to make sure everything works.
Yes, yes. So again, it's 300. That's probably a test question somewhere if it's not on our stuff. I had it in our EMT test question that I was asking how much suction. It's 300. Yeah, I don't really know about all this stuff. Physics. All right, here's our portable suction device. We talked about this. All right, our suction tips. What is this one called? This guy.
Trash. That's what it's.
Junk. See this cookie? This cookie junk.
Uh,
So this is a Yankauer. That's how it's spelled. Yankauer. Yanker. So this was actually designed in a dentist office. And so they were just suctioning up spit. And then they were like, let's put it on an ambulance. And now they suck. Because how many times do we just suction spit? We don't. Yeah, we got blood. We got teeth. We got chunkies. And so if you look at the port right here, there's a whole lot of not room for anything to get suctioned. Some of these are made a little bit differently than others. We don't have these on our ambulances, but if you are working on an ambulance that does have these, a lot of times there's a hole right here. There's a hole right here. You have to cover that hole with your finger for it to suction. So it'd be no suction, suction. So I've had where I like tape it before because I didn't want to hold a finger. I just wanted to. So I'll pass that around. That's a Yankauer.
Yeah, those are great. And
They
they had
suck.
like this big email chain go around because they were like, stop cutting the tips off these things. Because everybody was like, show up to work and cut the tips off of them so they actually work.
Yeah, because they don't. Unless it's like purely just blood or purely just spit, it does not work. So there's this amazing doctor. His name's James DeCanto. He came up with this suction tip right here. It's called the DeCanto. He named it after him. So imagine that. Crazy. This one doesn't have the little hole for your finger.
This one does.
I've never seen one. That's the first one. I did pull one out of the training thing.
I think this is the older model of the Decantos
Yeah.
because the newer ones don't. But just
If
part
it's
of the
not
paying
suction.
attention thing.
Yeah. I guess this one does have to. Little hole.
Yeah, that's why I said this is the older one because if you look at the angle on this one, it matches that one, but not that one.
Yeah, this is for the salad.
Yeah.
Okay, so you look, here's a picture, but I'm gonna pass these around too. You can see the diameter of this is a lot bigger and it suctions a lot better. So that's the Decanto, named after James Decanto, Dr. James. He came up with an entire technique of how we innovate that has changed medicine. He's that dude. So. And then you might see these ones. These are just soft tip suction catheters. These you guys are not going to use unless you're assisting ALS. This is like one of those things. You're going to see it, but it's good to know how to use one. But same kind of thing. I couldn't find one to actually like pull out of the ambulance to show y'all. But these, the green and yellow tips have holes like you would suction. Put your finger over those holes to suction. The same thing with this like little white part, that's where your thumb goes. So you can feed it down like one of these tubes to suction out stuff. For little tiny kids, if you need to do like a deep suction, do their noses. You guys can't do that, but that's kind of the stuff that it's used for.
Just a couple of learning points with these things. When you're using these things and you're like suctioning it out, I know that y'all's textbooks say like you suction coming out, not going in. It's fine. No more than 10 seconds. I think it's what y'all's textbooks say too. Right? Watch.
Never lose sight of the tip.
Yeah.
Mm-hmm.
Yeah, because you don't want to go shoving this thing in places that they ain't got no business being. But the big thing with these, watching their oxygen, watching their vitals, right? Because maybe on one patient you only get like 3 or 4 seconds of suction before their vitals start tanking on you. On some, you might get a little bit more than 10 seconds. For your textbook, no more than 10 seconds, suction on the way out.
So you
But pay attention.
put it in, suction, back and forth.
But
Here's the thing, if their mouth is full of shit, you suction until the shit's out. Because they're not going to breathe through the shit anyway.
Yeah,
so you might as well just get it out of there.
and then if you notice, the one that is being passed around or was passed around didn't have the hole. How do you suction that one only on the way out? Yeah, exactly. it's gonna suction going in and out, right? So just keep that in mind. When you're pulling this thing out though, don't fling it. I have seen, especially with the little ones that she had up on the board, the ones that she said that y'all can't use, the little wire ones. People love shoving that thing down and then just freaking smacking it out, this thing.
And it's like, ding, ding, ding.
Yeah, and it goes flop, and then all of a sudden get hit in the face with somebody's yuck. So whenever you're doing this and you go in and you're like suctioning, suctioning, suction, as you come back out, when you get close to the end of their mouth, just have purpose with bringing this out. Don't just freaking yah, because you're going to squirt everybody with freaking yuck, and then I'm going to yell at you. So just keep that in mind, just tidbits.
Kids especially, that's where I would really be considerate of that 10-second rule, because hypoxia kids are a little bit more sensitive to. The little kids, we use bulb syringes. Who in here has used one of these before? Perfect. So don't go into their nose, you squeeze and then come out. So I'll pass that around too. Hasn't been used, I promise.
Legend.
Have you guys seen the ones where like the parents suck on them?
Oh my God, that's so gross. I think it works really good.
Really?
Yes.
I've
I'm
never.
going to the dollar store and get one of these.
They have a filter on it.
Yeah?
Yeah.
Yeah,
Oh.
what happens is that filter break.
Huh?
Now you got a boogie.
No,
Yeah.
no, they just, so if you do this extra, filters,
Oh.
try to just put extras in there.
Oh, okay, well that works.
Shove them all in there.
Don't take
And
shit.
that one, like, you made it.
Really good.
Now,
I did.
Yeah. Whenever you're suctioning, always wear PPE. What is PPE? Good.
listen, I'm not wearing one of these things. That's why I said don't fling the thing.
I'll wear
I'm
one on a OB call, but
Yeah.
that's it.
Yeah, that's about it.
Yeah.
She probably will next time somebody gets shot. She's doing CPR too.
So anyways.
You're about to get kicked.
We're about to watch this grappling.
Billy's seen it. Billy knows how it goes down.
No, he has.
It's very aggressive.
Don't even worry about it. So yes, if you're messing with the dangly thing in the back of their throat, it's probably going to make them gag if they have a gag reflex. So here's another general rule. You're not going to find this in a textbook. To figure out if someone has a gag reflex without me shoving something into their mouth, I have learned, I had like a 30-year paramedic tell me this, and it was one of the greatest advices I've ever got. If you mess with someone's eyelashes and they flutter their eyes, even if they're unresponsive, if their eyes start to flutter as you're like, beep, 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 they're going to have a gag reflex. That's the rule. You're not going to find that anywhere, really. But I have learned that in my years of figuring out if someone has a gag reflex or not.
Trust me, I have done some interesting, because we had a lady one day that went unresponsive on me and one of my partners. I was an EMT at the time. I hadn't been on an ambulance for very long. And he was like, does she got a gag reflex? And I was like, I don't know. He was like, stick OPA in her. And the first thing I grabbed was the MPA, and I was like, I was like, he's not gagging.
Hell yeah.
So
Whatever works.
In the heat of the moment, you just got to get things done.
Yeah. Okay, so keeping an airway open. So you have devices that you can use with your adjuncts, your NPAs, your suction, your manual airway opening maneuvers. If you recognize that more definitive care is needed, a patient is profusely vomiting, a patient, you can't stop their bleeding in their airway. If their airway is closing for whatever reason, whether it be like anaphylaxis and you've given all the EpiPens you can give and they keep going back into anaphylaxis, make sure you call an ALS intercept. Call them early if you have that ability. Call them early, and then if at any point, not so much out here because we live so far from any hospital, if you are ever like called to divert from your closest hospital and they're like, yeah, go ahead, and you're driving and something goes really south, turn into the closest hospital again. So that's not so much of a thing out here, but if you ever run into that, if I was taking a transfer from here to Reno and they crumped around Fernley, I'm going to go there instead.
Can a patient do this for themselves? No. Absolutely they can. And I asked that because me and Becca had a 14-year-old that was shot in the face one day, right? And we're like doing things. Well, he's awake and talking to us. He just shot in the face. He's like profusely bleeding into his mouth. Becca was like, hold this, and anytime you feel stuff in your mouth, just stick it in your mouth. All the way to the hospital, he just,
Works like a charm.
yeah. So if they're awake and talking and they got some sort of facial trauma and they can follow your commands, hand this bastard to them and freaking, hey, if you feel it, like stick it in your mouth and pull it out. So,
Yeah, don't like put it in the hand of an unresponsive patient.
yeah, be like, do this at all. This guy sucks.
Don't do that. I put this meme up there just for Chess because he always likes to say pimping twist.
Good thing.
All right, so special considerations, bleeding may require frequent suctioning. I've had like patients where they have like facial trauma on the inside of their cheek from like their teeth or whatever. I've learned if you take like a good gauze pad, shove it in their cheek wherever they're bleeding, if they have an open airway, and then just hold pressure on the outside, that's a fantastic way to stop that. Obviously something like this, that's not gonna work.
How can you get suction? It's just.
Just follow the bubbles.
Oh, like everywhere.
Yeah, just
Yeah.
follow the bubbles, try and keep it out of their airway. That's kind of what we do for intubating something like this too. You just follow the bubbles. No.
I mean, she might have one good nostril.
Yeah, I don't know if it's gonna bypass the other shit, but yeah.
I mean, you can. It might make finding the blood easier.
Yeah.
Free.
Yeah. Yuck. All right, and then dental appliances. So if someone has dentures, what do we learn about bagging somebody if they don't have dentures in? We talk about it.
hard to
Yeah. Yes. So their cheeks like sink in. So if you can leave them in, do so. Like it's gonna help you manage an airway. It's gonna give that face shape and form. If they're loose and just knocking around in there, pull them out. Put them with the patient. Make sure they stay with the patient. These are very expensive and they like to get lost in the back of an ambulance. We pull dentures out and we're like, so I like to wrap them up in a shirt if they're like unresponsive, if they still have their shirt on or something. Put it in a bag, shove it between their legs, something. Keep their dentures with them because those are very spendy. But yeah, if it is helping you out, don't remove it. If they're glued in there good that day, leave them in there. All right, what questions do y'all have?
What is croup?
Croup is a
Upper airway
yeah,
infection. You don't know.
laryngobronchiotracheolitis. It's an inflammation of their upper airway. You see it in kids, and they get like this croupy cough.
You know a kid has it, they sound like a seal.
Yeah.
Got that like barking seals in it.
Why does keeping your head in the freezer help?
It doesn't.
Well, for croup it would,
Oh, well, yeah.
because it's inflamed. Cold makes things.
For the freaking old guy that's got congestive heart failure, that just think it makes you feel better.
Oh.
Did you really put in an MTA last year? Was it an OTA?
No.
Were you popular in high school?
No, I lost the bet.
Oh, yeah, you did. I vaguely remember that.
Who was the person that said they were gonna drink the tube?
Bullshit.
Oh, you don't wanna play no more?
No.
You got this, Steven?
That's how much.
Yeah, you got it.
Patient, man.
We can put it over some ice.
I think it's huge.
I
I thought it was like one of those little packaged liquid water bottles.
It's just a friggin' a liquid IV bag.
Yeah. Oh, no.
Yeah, typically, so like this is still within y'all's like scope.
You gotta learn it, but chances
Nobody
are you
uses
can't.
this. Yeah,
I've never used it.
honestly, this might be expert.
Is it like a powder in there or is it like a gel?
Yeah.
Literally about to squeeze this part and, anything over 100 pounds is a. Yep, that is correct. 1 gram per kilogram or half a gram per pound.
Yeah.
Either expect to throw up a lot or shit yourself.
Yeah.
So
You
who's
take
seen
them
the
out, throw 'em
word
up.
ad
I give respect to
baby
everybody.
on your, on your little sheets.
Say that again?
Who's seen the word adsorb, not absorb, on their little sheets, on their medical sheets?
It was on the.
So none of y'all have been looking at them things.
I know, I'm sure. I know. Yeah. Absorb,
Adsorb.
adsorb,
That was on my home spell.
yeah. Who can tell me what that means? How the charcoal works.
So doesn't it like bond to it, but it doesn't pick up all of it? Cause add is away.
I just read them.
Oh, I rewrote it. I was
Or because I think I
Yeah.
thought it was
I
wrong.
was
misspelled.
right?
That's funny.
It doesn't, since it doesn't absorb, it's not taking it into it, but it binds to the outside.
I did too. I put absorb. Adsorb. So it, yes, so instead of absorbing it, it coats, because it's used for what?
Overdoses.
Overdoses, yeah, poisoning by mouth or overdoses. So if someone takes a bunch of pills, it's within that time frame. Poison control might tell you to give them. What it does is it goes in and it coats all of whatever they just took and doesn't let it absorb into the bloodstream or the others. So it adsorbs it. So that's not a typo. I just wanted to make sure that I'm clear with everybody.
Is it basically throw it up though?
Yes, they, yeah, pretty much.
That's basically all it does. It's not what it's supposed to do, that's basically all. That's why no one uses it.
What is contraindication?
Just medication.
Drink the whole thing.
Yeah, so contraindications.
Absolutely.
I give them some medicine, but-
Like just to like a contraindication, but I was gonna rewrite it. I went through it.
I'd be totally shocked to see a lot of this.
You try it.
You try it, I'll try.
Cool. Any questions?
Yeah, we can split it in half.
Negative.
Yeah, you
Still
can,
buy them both?
that's an option. Both of you can put in
In each nostril. Just kidding, Callie, I wouldn't make her do that.
If they do it, I'm wrong for it. I'll give the bet to every class. I'm consistent.
Has anyone ever done it?
Huh?
Has anyone ever tried?
No one's ever even tried.